Hello everybody, this is Dr. Alexander, and just recording for you today a quick presentation for this week's lecture on First Aid 101. What you'll find through this presentation is that a lot of the drugs that we talk about in this lecture will be revisited in future lectures, so hopefully it will provide a nice review for you over time. Our objectives for today, we're going to talk about the general process for treating two types of minor wounds, those being a variety of wounds, but then we'll also talk about burns. So we'll talk about those two conditions, and the approach is slightly different between the two. As usual, we're going to differentiate patients who are not candidates for self-care. We'll try to classify the various types of agents into categorical groupings and describe how they're used and why they would be used. We'll also focus not only on the products, but also on the dressings and why you select certain dressings for certain types of injuries. Counseling points that are important, both for improved healing and also to minimize scarring. Other ways that patients can take care of that. And then also we'll talk a little bit briefly at the end about what should be in a patient's first aid kit, whether that's for personal or business use, and that's a frequent question that you get in the pharmacy. So in general, we look at skin injuries and describe them in a couple of different ways. One is the cause, one is the acuity, and another is the depth. And we'll kind of go through that in more detail. Acute wounds that are eligible for self-treatment would be things like abrasions, punctures, lacerations, and burns. And what that looks like is here sort of to find out for you. So when you think of abrasions, that's friction. It might be something like road rash. If you skin your knee, or if you think about like playing basketball in a gym, if you slide across the floor, maybe slide playing in a game of baseball, you're going to have some sort of friction injury to that outmost layer of your skin. A puncture wound would be a piercing wound. So that would be a case where something enters the skin and breaks it, and it can go somewhat deep just depending on how quickly the object is stopped from continuing to move into your skin, but it generally comes out clean. So most punctures are almost like a hole punch, if you will. Lacerations are your cuts, so they're going to be cutting through several different layers and usually cutting down several layers. And then you've got burns, and burns can be caused by a number of factors. So they can be thermal burns, which would be things like flames, or maybe hot objects. You touch a curling iron, you touch a hot pot or a pan handle on the stove. They might be electrical burns. So that might be something where you have an electrical outlet and you get close to either something that wasn't properly grounded or an outlet that wasn't turned off. Chemical burns generally have to do with coming in contact with acidic or basic substances. And these are always referred just because, as we talked about previously in that poison control lecture, we're not sure about the best practice generally to treat all of those chemical agents. But generally they do recommend some sort of washing. And then lastly, you get your ultraviolet exposures or your sunburns. And we will actually talk about those later on in the course, all in their own separate lecture. Okay, so we said that wounds are described according to cause, and they can also be described according to depth. And here's how we classify depth. So in general, the wounds that you're going to see that are self-treatable are your stage 1 and stage 2 wounds. And you may hear about this if you ever go on rotation with a wound care unit, or sometimes in surgical units, they'll talk about staging in terms of depth. Your stage 1 wounds are very superficial, so they're only impacting the very outermost layer of skin, the epidermis, with no loss of any skin layers. You're probably going to see skin that's reddened. It may not even be broken. and it might not be blistered. So usually those have to do with sunburns or superficial burns. So they're only injuring that very, very outermost layer. Stage 2 wounds are a little bit deeper. And sometimes they call this thickness. We'll actually talk about that in the next slide. But these get down into injury in the epidermis and part of the dermis, which is the second layer of the skin, second outermost layer of the skin. And those can be, again, sunburns that are more severe, but they can also be all of those other types of wounds that we discussed. So abrasions, punctures, and lacerations, and then, again, those more severe burns. These are going to be wounds that patients will complain of more pain and symptoms with. So in addition to pain, they may complain of swelling around the area or edema. They may complain of tenderness as well as redness of the skin. We also have to be considerate of the size of the wound. So while generally it's okay to self-treat a stage 2 wound, if it's a very large area, body surface area, we're going to have to be more careful. These are going to be the smaller wounds that we can take care of with self-care. A larger wound may still require something like stitches or further evaluation. Your stage 3 are much deeper. So these are getting into the lower layers of the skin, as are stage 4. And you can see there's a lot of skin tissue loss. And at stage 4, you may even be having exposure to muscle, bone, and tendon. In addition to talking about the staging, you may also hear people talk about more of a descriptive type of depth description. So you might hear someone say about a superficial wound. Again, those are generally the ones that just affect the epidermis. So those are going to be your burns. Pressure ulcers are related to sitting in one place, especially if you have like a bony prominence or something that's rubbing and causing friction. And again, it would just be a sore on that outermost layer. Partial thickness are going to include both the epidermis and dermis, and therefore that's why we get more into that stage 2 level of wound. And then your full thickness wounds are your stage 3 and 4, and they again go much deeper in depth in terms of the amount of skin layers that are affected. Something to keep in mind when you're talking about wound care is the healing process. So most people are not familiar with this, and it's important for them to be able to have a full understanding of how wounds heal to appreciate how to instruct patients. So at first, after you're injured, you're going to have the inflammatory phase, which is your body's initial response to an injury. It's going to last about 3 to 4 days. And what happens here is really the body preparing the wound for tissue development in the healing process. It's usually 2 parts. So there's a homeostatic response where you probably have clotting agents that stop the bleeding. They're going to potentially promote scab formation, trying to get the healing process to be able to start. But you're also going to see inflammation here, where debris and bacteria are removed from the wound by those inflammatory mediators. And the increase in blood flow is going to cause that redness, but it's also going to bring in agents that are important for building a new layer of skin to cover that wound. The proliferative phase is where the wound is filled up with new connective tissue and collagen to sort of recover that epithelium. And this will go on for about 3 weeks, which is why it's important to remind people that even though they may see some healing, that skin is still very tender and needs to be protected. So a lot of times you have to bandage longer than most people think. And then maturation or remodeling is actually the longest phase, and it starts about 3 weeks after injury and can continue on at least 60 days after injury. This is where collagen continues to build up and strengthens the underlying layers of the skin. So you can tell wound healing is a very, very long process, which means patients need to be somewhat vigilant. There's lots of factors that impact wound healing. So we have to think about how well is tissue perfusion happening. That's really talking about the delivery of blood to the capillary beds. We may also talk about vascularization, which is how many blood vessels are flowing to the area, because again, blood vessels are bringing both healing promoting agents as well as taking away anything that's impeding wound healing. And then how well is the tissue how would you say that? How much oxygen is coming to the tissue area? If there's not enough oxygen, you're going to have poor collagen production, a decrease in the skin development, and honestly, potentially a reduced resistance to infection. So you need some oxygen for the tissue to heal, which when we get to dressings is really important. It's why we need breathable dressings, not occlusive dressings that are going to keep any airflow from getting to that wound bed. There are several conditions that can cause poor perfusion, vascularization, and oxygenation. And those would be diabetes, severe anemia where they have low iron, potentially low blood sugar, other cardiovascular conditions, and obesity. If there's a presence of infection, it's likely that it's going to delay wound healing because it prolongs that inflammatory phase. So that's important to know. The most common bacteria that's going to lead to infection are Staph aureus. Wound characteristics, what we're thinking here is the presence of necrotic tissue. So tissue that's dead or decaying obviously is not going to heal. The body has to actually get rid of that before it can replace it with new healthy tissue. If there's a scab or eschar, which is the official name of scabbing, that can actually slow wound healing. And then any foreign body that's present, whether that be debris, you might think of things like shrapnel in more severe injuries, but that can sometimes keep the wound from healing as quickly, mostly because it's infection promoting. Inadequate nutrition is important to consider because nutrition is going to provide the building blocks for wound repair. And here we're thinking specifically about lots of vitamins as well as copper. So making sure that patients are on a multivitamin or a good diet is important, as well as having enough iron, because red blood cells are going to be a key factor when we think up to bringing oxygen to that tissue. As far as coexisting medical conditions, we've already talked about the role of diabetes, limiting sometimes that vascularization to tissue. So diabetics in general have a harder time healing wounds. And then lastly, medications like chemotherapy or anything else that's going to suppress the immune system is going to slow the patient's response. When we talk about figuring out how much of the body is impacted, we use something called the rule of 9, which you can see here. So the rule of 9 basically is a quick method for establishing the percent of body surface area that's involved with a burn or a wound. Generally, with most wounds, we're looking for 1 to 2% body surface area affected to be self-treatable. So you can see there that might be something like a cut on the forearm or a scraped knee. It's not going to be a very substantial burn across the whole body. We would be very, very cautious about how much of the body is affected. And so just for example, you can see here that the front of the right leg, for example, makes up about 9% of your body surface area. And then an additional 9% is the back of that leg. Your core, so shoulders down to hips and groin, will make up about 18% on the front as well as 18% on the back. And then arms are generally about half of the body surface area that legs are. So we need to figure out how much of the body surface is involved. Other things we're going to look at with the wound is, are the margins jagged? So you might think of a puncture in this way. So remember I said a puncture is like a hole punch. And if something goes cleanly in and out, it's not, it's only affecting a certain amount of tissue. If something drags across the skin and comes out at a different angle than it came in, it's creating more damage, and that can be problematic. Exudate or odor coming from the wound, exudate would be drainage. That's likely a sign of infection, so you'd want to be very cautious of evaluating the wound and what does it look like, what does it smell like. Healthy wounds should not smell. Are there any other systemic signs of infection? So is the patient complaining of an elevated fever, or are they just not feeling good, complaining of chills or sweats, things that might indicate a fever? How painful is it? So obviously there's probably a pain threshold where we would feel comfortable self-treating. And then lastly, how much redness or swelling is present. And again, trying to figure out if it looks to be maybe a worse situation. So here you might be thinking of something where it might be a broken bone along with some sort of wound, and that would present with much more significant edema. So in general, when we're talking about exclusions to self-care, we're going to focus on those two categories separately. So one for burns and exclusions for burns, and one's for exclusions for just those different types of wounds. With burns, again, anything that hits into the depths of the skin is obviously not self-care appropriate. We've already talked about that. We really try to limit to about 2% of the body surface area. Anything involving the eyes, ears, face, hands, feet, or perineum, that's just sensitive tissue. And so generally we probably want to be more cautious with burns in that area, and we may not be able to provide any agents. For example, if you have a burn on the eye or the ear, there might not be anything that you can really recommend for a patient to help that. And it may be more prone to long-term risk. Although you all know you've gotten sunburn on your face, and that's not a reason that you go see a physician. So it's very much at your discretion. We always refer patients with chemical, electrical, or inhalation burns on. We're more cautious with people of advanced age, with diabetics, and with immunocompromised patients. So it says general exclusions. It's going to be, again, at your discretion, but really use, I think, your gut to figure out how bad or how significant is this looking. As far as wounds go, again, the deeper the tissue involved in the injury, we need to refer those on, likely because they're going to need stitches or some sort of other more advanced treatment to ensure that tissue heals. Again, we're cautious about sensitive areas. If a wound won't stop bleeding, it might be a major artery or a vein that's involved in the injured area, so that would be a reason to go on and seek additional care. If there's foreign matter that's in a wound after you've rinsed it out, that's going to be more prone to infection, and so you may need to get someone to go in and remove that with tweezers or some other procedure that a medical professional would be best suited for. Wounds secondary to animal bites may require additional vaccinations. We think of things like rabies, other communicable diseases, and so that would be, again, a sign that you'd need to refer on. We talked about infections previously. If it's more of a systemic infection, may require antibiotics for that wound to properly heal. If it's a chronic wound, a wound that's just not healing very quickly or at all, that's a concerning sign. And then lastly, patients with diabetes are on this list. But as we said with burns, it's not necessarily always the case that we don't treat them. I routinely recommend wound care to diabetics. We just need to be much more careful because they are prone to having limitations to their healing. We're going to go through these almost one by one, but as far as the goals of wound care go, this is sort of our stepwise progression. So we need to figure out what's causing the wound and remove exposure to that. Then generally we clean and stop the bleeding. We're going to talk about cooling a burn, which stops the further irritation of the skin. Ultimately, we want to make sure that we're providing pain relief, but also making sure that the wound's going to heal up nice and not get infected, which is going to slow healing. So they're going to counteract. We're going to try to prevent any further trauma to that area by physically protecting the wound. And then we really want to minimize scarring. Most people are not, especially if it's in a visible area, they're not going to want to have these huge noticeable scars from any wounds that they might have. So that's something else that you need to be mindful of. We are going to split out again between wounds and burns. So we're going to start with our wounds, our abrasions, lacerations, and punctures. And step 1 and 2 really kind of happen together. So I have here step 1 is to cleanse the wound. The reason I put this here is, we'll talk about that here in a second once we get to step 2, but cleanse the wound, make sure that all of anything that's debris, so whether that's dirt or some sort of particulate like glass, make sure that's all out of the wounded area. And you can do that with saline or just water. Water is fine. You may have to mechanically remove it. So you may have to go in with tweezers, with your hand, with a washcloth to kind of scrape it out. And generally we advise that you use a mild soap and cool to warm water, not super hot. We don't want to irritate the area further by putting scalding hot water on. But we just want to make sure soap is going to help us remove any additional bacteria that's present that could contribute to infection. They do have antibacterial soaps or antiseptic soaps, things like HIPAA you see commonly used in operating rooms and hospitals. That's likely not something that I would sell to a patient for a first aid kit or with an injury. Good old Dial soap works just fine. Sometimes you'll see patients though after surgeries, if they have a major surgery, maybe like having like a knee replacement, they may recommend HIPAA, which is a chlorhexidine rinse, as the soap of choice to help prevent any sort of infection. There's also antiseptic wipes, but again, due to antimicrobial resistance, I think good old soap and water is just the way to go. So once the wound is cleaned, you then have to stop the bleeding. And the reason I say sometimes these both have to sort of happen together is if you stop the bleeding first and then go to cleanse the wound, you're going to wipe away most likely the clotting factors that are stopping the bleeding, and you're going to have to re-clean it. So, and then stop the bleeding again. So I generally tell people to cleanse it and then stop the bleeding from a clean wound. You don't need to use a tourniquet. If you do, that's a sign that you definitely need to refer that patient on, because that's a very, very deep wound. So no like tying something off tightly at a proximal source. Just put direct firm pressure, usually with the protection of either gauze or cloth, and just keep that on the wound for a couple of minutes. And ideally you're positioning the wound above or at the level of the heart. And that has to do with staving off blood flow to the area. So it should slow the bleeding quicker. If that doesn't seem like it's happening, if it's not stopping, or the wound meets any of those exclusion criteria, again, refer. But applying pressure should be sufficient to stop that bleeding. There are also clot promoting agents. A lot of these have come out with the use of single blade razors and shaving kits. And they basically accelerate blood clotting to stop bleeding. They're especially helpful for small cuts or cuts in areas that are highly vascularized. They do provide a warming sensation, so that's something that you may notice if you use something like this. And there's a couple different agents listed there. And basically all you do is place the product, whether it be a powder or a sponge or a little bar. Just place it over the wound, apply pressure, and leave it in place until the bleeding stops. Okay, after you've stopped the bleeding, next you need to put on some sort of topical product. And this is going to depend based on the patient's complaints, based on the type of injury, and based on the presentation. So the various types of products that we have available in most pharmacy areas, and these can be sometimes listed under first aid, sometimes they're just listed under dermatologic products. So the categories are sometimes different. But we're looking at skin protectants, astringents, antibiotics, antiseptics, anesthetics, antihistamines, and anti-inflammatories. So the first option are your skin protectants. And these just help make the wound area less painful by protecting the skin from any sort of mechanical irritation caused by friction or rubbing. They also prevent the skin from drying out, which we'll hear later on is really important to reduce the risk of scar formation. There's lots of different agents. Most of these products contain very bland agents, so things like cocoa butter, white petrolatum, they're just moisturizers. Calamine lotion, a lot of people remember it as something that their parents used when they had chicken pox when they were little. Calamine gives your skin kind of this pink tinge, and zinc oxide will give your skin kind of a white tinge, but they're not really medicated. They just help protect, literally. They're skin protectants. As far as application, because they're non-medicated, these can be used as much and as often as the patient wants. I would say the only kind of tip here would be if it's an ointment, it's going to be greasy, which means it might be kind of greasy on clothes. And again, those there's several agents, the calamine and the zinc oxide, that can cause skin discoloration, so that might be something to just let them know. Astringents are used in wounds that are weeping. So if you provide an astringent, which usually is a soak, so the Domboro solution there that's shown on the slide is a soak. It's a powder that you pour into water, and it helps with the delaying of oozing, discharge, and bleeding. And it's going to have a cooling sensation, and it does this by constricting the vasculature, which is going to decrease blood flow and hopefully decrease all of those symptoms that you want to get rid of. The nice thing about that is that in turn kind of cleanse the skin of any debris or exudate or crust that's built up as a result. There's two different agents, aluminum acetate, which is in Burroughs solution, and witch hazel, which you can buy over the counter. And as far as these go, again, they are soaks, so you can use them for about 15 to 30 minutes, up to 4 times a day. You can also do them as a compress, so maybe soak a washcloth into the soak and then place it on a body part that's affected. Topical antibiotics are going to prevent infection, and these are especially useful when you have debris or some sort of foreign matter in the wound and you're not sure what the contamination is. This is going to prevent any, potentially any infection. These are all sort of mild antibiotics, so if the patient has clear signs of infection, these may not be tough enough to really make a difference. A lot of times you'll see them referred to as triple antibiotic ointment, and that's because the majority of them do contain the 3 agents listed: bacitracin, neomycin, and polymyxin B. Neosporin is also known as a triple antibiotic ointment, so it contains all 3. Polysporin, the other product listed here on the slide, actually does not include neomycin, and the thought is that the reason it doesn't is twofold. One, because of resistance to neomycin, and secondly, because of the high rate of sensitivity that some patients have. So some pharmacists will always go with polysporin, others are neosporin fans. I don't really have a preference. I think they both work equally effective, and these are to be used after cleansing, but before you put on a dressing, up to 3 times a day. Yep, there they are, triple antibiotic ointment. Next are your antiseptic agents, and these are used to disinfect wounds. These are either alcohol products or peroxides, can be iodine as well. And these are applied only to clean, dry skin. And generally you only use them kind of right with initially when the wound happens. You don't use them ongoing. Mostly because they can be very drying to skin, alcohols especially. And you want to be careful about bandaging over these. So I don't generally see antiseptics used very frequently or long-term with wound healing. Anesthetics, these are going to be your numbing agents. So they provide pain relief by numbing the area, and that pain relief lasts for about 15 to 45 minutes, so not a significant long time. By numbing the pain, you can also sometimes reduce itching and irritation. A lot of times you'll see these with use in burns, especially sunburns, but people can use them in cuts and scrapes as well. And the active ingredients most commonly are things that end in cane. So benzocaine, dibucaine, and lidocaine. But there are also other agents as well. And these, again, use about 3 to 4 times a day. And we don't want to use them any longer than 7 days because sensitization can occur on the skin, which can actually cause rash formation and actually more irritation. Antihistamines are used to treat pain and itching. So there's a Benadryl product that's actually topical diphenhydramine. Again, 3 to 4 times a day, no longer than 7 days. Again, the limitation here is because of potential for sensitivity reactions to develop if used too long. And then probably my favorite topical product are the topical anti-inflammatory agents. This is a topical version. Think of it as a topical version of ibuprofen. So it's going to target inflammation. And if we relieve inflammation, we're going to also relieve sometimes the pain and itching. If you think back to the very beginning of the presentation, I talked about that there is an inflammatory phase that lasts a couple of days. We may want to wait at least a day or two after injury before putting this on so that we get the good benefits out of having some inflammation at the site of the injury. The active ingredient in anti-inflammatory products is hydrocortisone. And again, you apply this one 2 to 4 times a day, only on the infected area and only a thin layer. We don't want to have any overexposure for patients. And that can happen if you put it in with broken skin over large areas, wrap it really tight, and use for a prolonged period of time. That can lead to too much exposure and ultimately have some problems. Okay, so generally what do we counsel patients on any of those topical medications? Well, they need to wash their hands ideally before and after they apply, especially after though. You don't want to put a product that might have a numbing effect or might have a burning sensation in your eye or another sensitive tissue. You don't want to apply extensively across the body just to the injured area. And just like we talked about way back when with musculoskeletal injuries, you don't want to wrap a real tight bandage around the agent because it's going to cause a localized reaction or systemic absorption, both of which are not ideal. You may have heard in the news about honey and might be curious about the use of honey. And actually there's a lot of people who really stand by this. Why? Well, we'll find out here in a second, but we really like a moist wound healing environment. And honey, because of its hyperosmolarity, is going to provide that moisture. It's also going to absorb anything that the wound seeps. And come to find out, it has antibacterial, anti-inflammatory, and antifungal properties. So it's actually super advantageous. The ones that agents have been studied the most are Medi honey and Manuka honey. And Manuka honey is thought to be especially beneficial because of the area in which it's grown. It comes from, I believe, either New Zealand or Australia. And there's something about the plants that the bees use in making that honey that gives it extra antibacterial and anti-inflammatory effects. There's a ton of different formulations and dressings, but I would just tell people to only use medical grade honey. Don't use something that you buy at the farmer's market. Don't use something that you harvest at home. It really needs to be, I don't know what the word would be, like pasteurized probably, or appropriately bottled so that you're not introducing other bacteria into the wound bed. And you don't want to use it on wounds that are bleeding or in patients that may have any sort of allergy, especially to honey. Okay, so we've cleansed it. We've cleansed the wound. We've stopped the bleeding. We've applied a topical product. Now we need to cover it. And I've already alluded to, but one important component of wound care is that we maintain a moist wound environment. Moisture is going to really help us with healing and minimizing scarring. It's going to help us remove anything that's weeping out and keep bacteria from coming in. So what are we looking for in a dressing? Well, ideally it's going to be something that's protective, that's hydrating to contribute to that moisture. It's insulating, so it's keeping any sort of trauma, I guess, out. It's absorbing anything that's weeping out of the wound, and it's allowing for oxygen to flow in, because again, we know that that's helpful in the healing process. There's lots of different options. So you've got your gauze, which are your absorbent dressings. You have dressings that don't stick, which generally are gauze-like. You've got adhesive bandages, so things like Band-Aids, things that we're most familiar with from giving vaccinations, for example. And then a whole lot of specialized dressings, and we're going to kind of go through all of these various ones, but it's overwhelming. There are a lot of products on the market in the wound dressing aisles, and I'll tell you that some pharmacies, especially independent pharmacies, will specialize in wound care, but they'll hire people specifically that know these products. The other thing is that a lot of physicians who have patients with significant wounds oftentimes will be very specific about what they want their patients to get. So that can be really helpful for you as a pharmacist if this is something that you're not particularly familiar with. So in general, you've got a couple different types of dressings. You got your primary dressings that go straight on the wound surface. You've got your secondary dressings that hold those primary dressings in place and provide additional absorption and protection. And then you have your non-adherent dressings that are really best for wounds that are sort of flat and not weeping because they're very breathable. When we talk about specialty wound dressings, and the reason this is here is A, because you can buy them over the counter, and B, we don't really talk about them anywhere else in the curriculum, so I'm just going to kind of go through very quickly. There's different types of dressings for different types of wounds. So you may look at a dressing that absorbs moisture. So maybe it's a weeping wound, a wound that's, especially in the inflammatory phase, that's getting rid of a lot of exudate. Foams, alginates, and antimicrobial dressings are going to pull that off. Maybe you want a dressing that's just maintaining moisture. Your hydrocolloids and your transparent film dressings will do that. They'll just maintain the wound environment. And maybe it's a very dry area and you need to provide some moisture, and those are your gel type dressings. Here's what they look like. These are crazy expensive if you ever work in a pharmacy that has these types of products. So again, I generally say that your physicians will, they'll tell the patients exactly what they're looking for. So starting up at the top left, your Alavin dressing, that's a foam. The Keldostat is an alginate product. So again, that's going to be an absorbent dressing. Then you've got the NuDerm, which is a hydrocolloid. That one is going to just maintain wound moisture. Your Duoderm is also a hydrocolloid. Your Tegaderm is a film dressing. So again, that's just maintaining moisture. And then lastly, your Anticoat, or Acticoat, I'm sorry, is an antimicrobial dressing. It's actually got silver and iodine that's released when exudate comes in contact with that dressing. And so that one is specifically antimicrobial and would be used in weeping wounds. What are the ones that 99.9% of your patients are going to ask for? Well, they're your adhesive bandages. These are most commonly used. They're great for superficial wounds. The big thing you have to think about is the size. So how are they going to fit on the skin? There's lots of different shapes and sizes. You want to make sure patients are buying one that's appropriate for the injury that they have. You'll see in the middle there's the Band-Aid Advanced Healing. That's actually a hydrocolloid-based Band-Aid. So if you think about a couple slides back, those are going to be the ones that they'll add moisture to a wound environment. And so those might be great, especially if you're trying to minimize scarring. If it's on top of someone's hand or on near their face, that would be something maybe to consider. And then they do also have liquid bandages, which sometimes I like for things like paper cuts or small scrapes on the hands, places where Band-Aids aren't going to stick well. Okay, so just kind of going through the selection process for wound dressing. Again, if we have sort of unbroken stage 1 skin, our biggest focus is to protect that, and we're going to use some sort of adhesive bandage to do that. For a stage 2 wound that's a little bit deeper, likely bleeding, maybe weeping somehow, we really want to have a lot more properties to our dressings, and so we might be looking at additional gauze, additional bandages to make sure that we're pulling that moisture off. And then again, stage 3 and 4, these are the ones that come in from another location, specific with recommendations from their physician. There's other wound care products that you might see. So there's adhesive tapes that can hold gauzes in place. Those can be paper tape or cloth tape, or the super sticky clear surgical tape. Personally, I would not sell that to anyone because, and then I'll take a layer of skin off just removing that stuff. There's absorbent sponges or gauze sponges. Those are great, again, if the wound is weeping. And then there is a wound wash that is sort of an aerosolized sterile saline that might be beneficial. So things to counsel patients on: make sure they're selecting the dressing that's the right size and contour for the affected area. Make sure that they're using the dressing until the wound bed has fully closed. So a lot of people will tend to want to take the dressing off quickly because they are somewhat annoying to have to change. They're sticky, but try to encourage them to keep it on until the wound's closed up fully. Otherwise, they may be at risk of scarring. Avoid changing the dressing too often. At most, aim for every 3 to 4 days. If it's weeping, you may have to change it more often. And then you want to always keep them in their original packaging away from moisture, just to make sure that they don't lose their stickiness. Okay, so we've got the wound dressed. Now we need to think about other ways to reduce symptoms. One way might be to reduce swelling by applying ice. And that can be indirectly, so usually it's, we'll have some sort of washcloth or some sort of cloth or barrier between the ice and the skin, and applying that for about 15 to 20 minutes about every hour. But you always want to have an ice or a barrier between the ice and the skin. And usually your inflammation goes away pretty quickly. You might consider systemic medications depending on the symptoms. So an oral analgesic is going to help with significant inflammation. An oral antihistamine might help with something that's very, very itchy. It's just going to depend on the patient's symptoms. And then you want to have the patient reassess. So after a day or so, does the wound seem to be getting better, or has the pain worsened? If it's worsening, we probably need to refer. That might be a sign of infection. If about a week out, are we seeing signs of healing and not seeing any signs of infection, meaning the wound is smelly, it's malodorous, it's weeping, it's pus. If we're not seeing signs of healing, then we need to refer on. And then ideally tell them that healing is going to take about 2 to 3 weeks. There are some agents over the counter that are specifically targeted to scar prevention. And again, your dry wounds are going to will lead to scabbing, which can lead to scarring. And so proper wound care really can minimize scarring from the start, but there are products that you can use after the fact to diminish appearance of scars. And generally these products are going to have active ingredients that are usually just moisturizers. So a lot of times they're skin protectants. They may be sunscreens. Again, they might be bland ointment bases. Sometimes you'll see things like vitamin E and green tea. I personally have never seen a lot of effectiveness with these, especially with older scars. You also have products like Mederma out there. Mederma is a natural product. So the active ingredient is a botanical extract. It's actually onion extract. It claims that it improves the overall appearance, color, and texture of scars. And so you have to be kind of careful with patients who have any sort of like allergy to bulb plants. And the product ironically does list this onion bulb extract as an inactive ingredient, and it says it's part of the formula that works to improve the overall appearance of scars. So the other agents in the product are mostly skin protectants or bland agents. One thing I think is interesting is you have to use this for a very long time. So you can begin applying it a couple weeks after injury, after the scar has, or the scab has come off naturally. Don't apply it to broken skin. But if it's a new scar, it takes 8 weeks of application for this once a day. If it's an older scar, it can take up to 6 months. And the cost on this, it's about $25 for a 0.7 ounce tube, $35 for a 1.7 ounce tube. So it's pretty expensive. And that's something that you'd have to make sure patients knew. They can't just use it for a week. They're going to have to use it for several months. Now we're going to move on to burns. So similarly, the first step with a burn is to soothe it. If a burn occurred in the last 20 minutes, generally the first thing you do is run it under cool water. Cool or sort of room temperature water for 10 to 30 minutes. You can also put a cold compress on. You want to make sure it's clean, loosely covered to prevent any sort of infection of the area, and don't put any sort of oily substances on. Sometimes there's a lot of home remedies that can involve oils, and that can actually be more problematic, so that's a big no-no. You don't want to apply ice. That's going to be actually too constricting and can cause damage. So we've cooled the burn. Now we want to cleanse the area. Again, just with mild soap and water. You don't need to use antiseptic wipes. You don't need to use rubbing alcohol or anything like that. And just kind of pat the area dry. Then we can apply topical medications, and it depends if the skin's broken or not. So is it blistered? Is there another sort of wound present along with the burn? If it's unbroken, generally we're using a skin protectant or a topical anesthetic, maybe both. If it's broken, we're probably using a topical antibiotic because there may be more of a risk of infection because that skin is compromised. You never want to put menthol or camphor or counter irritants on a burn, even though they seem like they'd be cooling. Something like Biofreeze actually is just going to be much more irritating. Because we've talked about all of those products previously, we'll talk about another natural product that's specific to burns that we haven't mentioned, which is aloe vera. So aloe actually reduces pain by inhibiting prostaglandins. It's going to have a similar anti-inflammatory effect, and it sometimes also has antibacterial and antifungal properties. This one you use 3 to 4 times a day as needed. It's only meant to be used on intact skin. You can buy commercially available products, but you can also just break off the leaf of an aloe plant if you have one and use the substance within the plant itself. And again, patients who have any sort of allergies to bulb plants, things like garlic, onion, tulips, wouldn't use these either. Now that we have cooled it, cleansed it, applied our product, we need to wrap it. And generally, if it's not blistered, usually I tell people just to wear like long sleeve shirts, something that's cotton. You might try non-adherence gauze dressing if it's a really bad burn, especially like on a stove or something like that. If it's blistered, you probably want to put something that's going to provide moisture. You do not want to rupture the blisters, so try to keep them intact if possible. You don't want to wrap it super tight or use anything occlusive. Remember, we need good oxygenation. And then for sunburns in particular, we want to try to keep any further burns from happening. Again, we're going to reassess. So if the pain's worse in a day or two, we got to refer those people on. Or if the swelling is expanding, we need to refer them on. And then we should see signs of healing within 5 to 7 days. Lastly, we're just going to quick talk about a first aid kit. And this is generally what's recommended. You'll see a mix of topical products and oral agents. And this is just based on the most common acute injuries that patients might come in with, either at your workplace. There's all sorts of cool ones you can buy. They have ones for your car. They've got ones that you can stick in your desk. Maybe you stick it with your fishing stuff, or something else if you're going out on an activity that may involve an injury. So topical anesthetic spray, hydrocortisone, and antibiotic ointment, probably the most commonly used. Usually some sort of sunscreen and insect repellent. Oral agents, we're thinking about analgesics, antidiarrheal agents, and antihistamines, mostly because you can also use those for bug bites and stings. We'll talk about that later in the course. And then it's never a bad idea to have an EpiPen or epinephrine in your first aid kit, just in case anyone has an anaphylactic reaction to something. You might also see them contain dressings, so things like adhesive bandages, gauze, some sort of tape, sometimes roller bandages for stabilizing areas or a finger splint. A lot of times you'll see gloves and scissors, maybe a cold compress, and then some other random things. So you might find safety pins, a resealable plastic bag, a Swiss Army knife, just other things that you may need to use in an emergency situation. And a lot of times they come all bundled together in one of these handy dandy little packs. And that's pretty slick, so you can actually buy them all pre-assembled. In general, a couple of first aid tips that are important to know. If you find a patient who's been involved in an accident, as a pharmacist, we are sometimes in a first response situation. So if there's a patient in your pharmacy's parking lot who is injured, what do? Well, just like with CPR training, you first have to make sure that the area is safe. You never put yourself or others in a dangerous situation to help someone else. You always have to kind of balance that. After you've made sure the area is safe and secured it, call 911. And then they'll always recommend that you do not move the patient. You want to stabilize them and wait for paramedics because you're not sure what the injury is, and we are not trained to evaluate that. So leave them be unless the scene becomes unsafe. So if there's a fire, if there's some sort of other danger, that's really the only time it's recommended to move a patient. And then you may want to keep Poison Control's phone number, which is 1-800-222-1222, in your first aid kit, just in case you ever have an ingestion issue. With that, we are wrapping up today's lecture on first aid. And I will actually be talking about this with you all at the end of the semester in our course review. And I hope that this serves you well as you move on to other derm topics.